let's say you start your day and you're mentoring somebody else, right? And that person is, needs to have a number of skills before, they've moved on and they're maybe later on mentoring somebody else. So what they're looking at today, you're looking at what are we going to do today, and ECG is part of, we want to make sure that people are there. Right? And that person, you ask them a simple question, and the question might be, so on a scale of maybe 1 to 10, where would you put yourself, for ECG interpretation? And it's like maybe, just give you, like 1 would be, I got flatline wrapped. I'm good at flatline. And 10 would be, I really should be teaching you. All right. And that person says, I think I know what a P is and what a QRS and what a, I said, okay, so where would you put yourself? I think it may be a 2 or 3. I said, well, I think in a couple of minutes we could probably, get started on that. And then maybe through this next couple shifts that we're together, I can show you some tools to go to. And the truth is that, I think it's going to work because it works for me. Right. And I did change my ways. I went from memory, and then I learned this approach. And 3 steps seemed to actually work for me. So that person, nods, and it's like, we don't have a lot of time, but let's just take a piece of paper and I'm going to write out, nice, simple. It's like when you take a look at a normal ECG, and that already. He's got a P, and then there's a space after. And then there's this big wave called a QRS, and then there's a space after, and then there's a T wave. It's like if we unpack this, we know that there's an atrial wave, there's your P wave. Right? We got a little time in between, and that's the time for the impulse to get through the junction. And then we got this big QRS, but look at it's not very wide at all. It's like hardly any time. Got a little bit of a line after. Well, we're going to keep an eye on that because we don't want those things. And it's like, and you ask the person, what's that for? And they say, I worry about that because it could be having cardiac ischemia or infarct. So you got it. You definitely got some skills here. And then that T wave is just a ventricle coming back to normal. Now, each one of these, if you look at this, you go, okay, of all this, I'm going to say probably the most important thing of this PQRST is how soon the next one comes. All right, so as much as you've got a complex here, and we got the PQRST, probably the most important thing to start with is how many of them are coming in a period of a minute. Right? You're looking at that, and the heart rate's coming back at 82, great, all right? But if the person's heart rate came in at 135, what would you be thinking? And then this person says, well, that means they're, for some reason, they're, I don't know, maybe they need it. Right? So you're totally right. Like, that's the thing. That's actually the most common reason that, that sometimes people miss. That the 135 is exactly, it sits within a physiological range where the sinus node's firing faster. And it's like they need it. And then the question is why do they need it? Now, if we don't know that yet, what are you going to do? And that person says, well, I'm going to go and check the patient out. And would you be surprised if their blood pressure is 78 on 40 and they have a temperature of 39.5 and they're having problems? You met them before. Yesterday we saw them and they were talking to us. But we were worried about them starting to develop an infection because they were starting to develop a fever then. But today, things better. He says, no, things are worse. All right? And are you surprised that you find that their blood pressure is softer than yesterday? No, this sounds like they're going septic. There we go. Heart rate, important. So then heart rate's number one thing I want to be keeping an eye on, and does it fit the picture? So that's, if everything, we forget everything else, that's going to be our most important thing. The second thing is the QRS. Now we're starting to name things. Mostly you want to talk to other people. You want to be able to tell them where this thing is coming from. You got a heart rate. We want to tell you where's it coming from. Is it coming from the top of the heart where it normally does? Or is it coming from the ventricle? Now, the width of the QRS, the width of the ventricular wave, is what gives you something that happens so fast across this big, big ventricle. Right? And just to let you know, just draw the picture out. It's like the ventricle itself doesn't have one impulse crossing it like the atria does. It has 4 happening all at the same time. So each one of these 4 waves shortens the distance. So together, those 4 waves reduce the amount of each wave has to travel, and that less distance gives you increased speed. So you need 4. But the only place for these four to start is at the junction, which means you start to see that on the picture. It's like if something's coming from the top, it's probably going to use all four, which means if it's coming from the top, that's what's going to give you a QRS that's narrow. So when you see a QRS that's narrow, what does that mean? And the person says, it's probably coming from the top. That you got it. And then the flip side of that, well, the flip side of that, let's say, and I put a dot on that piece of paper, and the person says, and I say, maybe ask the question, how many waves now? And the person says, well, only one. In fact, yeah, now that wave's got to do all that ventricle and come around and do the other one. That whole wave's got to do all the distance. It's going to take more distance, and it's going to take more. And then the person says time. So the QRS would be wider. So when you see a QRS that's wide, what does that probably mean? It says that it's probably coming from down there. Yeah. So we would name it that way. It's coming from down the ventricle. And then, but here's the thing, and this is the last thing we're going to talk about because we got to get back to work here. We're going to actually, what happens if we have a Bunner branch block? In fact, let's see the right Bunner branch block. Well, are we still seeing four? So no, we're down to three. So each one of these have to travel a bit further. So it's going to take more distance and more time. So the QRS is going to be, yeah, a little wider. Or if we have a left Bunner branch block, we've gone from four down to only one, and that's going to look almost like it's coming from down here. How would I ever know? Is it a Bunner branch block where it starts from the top, or is it coming from the ventricle? What would you see if it was coming from the top and it was a Bunner branch block before every QRS? The person says, I could see a P. I said, you got it. So you always want to go to step 3. Right? Even if you see a wide QRS, you still want to see, is there a P in front of every one? If there is, it's come from the top. If it's not, it's coming from the ventricle. And that is enough for today, right, to be able to look at these rhythms. So we're going to go to that room now, and we're going to look at these monitors, and we're going to take a look up there and see whether or not you, and I'm just going to ask you a quick question. Does the heart rate fit the story? And does that QRS mean things are coming from the top or bottom?